not so much an analytic approach that you break apart the doctrine and all those small competencies. Actually, what you do is you bring those competencies together in EPAs, and each of these EPAs, those units of practice, require all those things in concert to work together, and you want to assess them at the same time as a holistic approach. So here, if you would then say this person is competent, what actually is that? In education, you could consider that as when professional activities do this by yourself. And competent then is a stage in a development in a continuum. There are many publications in the literature show actually the same shape of those developments. And I like the framework because in the middle of that development of experts that we deliver, we want to make sure that they pass that threshold that allows for our trust in all the essential units of practice that we have developed in our more unsupervised practice. It could be at different moments. It has met all our standards for this EPA, and we think this person is ready to work unsupervised. And in that sense, their professional practice. Here's an example of another EPA, and I think in training or even earlier. But if you never practice afterwards, maybe we should maybe lose our trust sometimes. So let me delivery of a healthy, from a healthy pregnant woman and a healthy. One is a resident in the quartile 1, and one is a resident in quartile 4. And so the quartile, by elapsed years of experience, since see here, so look at quartile 1, which were the right after residency. But after a while, they actually do much better and better and better. Pretty good. Stays at that same level, and they're still under the mean of the number of the complication rate. Basically, if you put all these together, this is a different graph. But you can see that the complications of individual specialists who deteriorate actually, maybe because they have stopped. This was just an example of how we think of using EPAs and programs. Now, I talked about unsupervised practice or not or supervised. It means that level of unsupervised practice, and we actually useful to put into your undergraduate learner over time. Here is the postgraduate 4 years after 4 EPAs, and you can see that level A in your third postgraduate year. But we will monitor you, and if you are very quick, it might be in the second year, or you're not as quick, it might be in the first semester of your 4th year. So they have to monitor that, but to reach that level that we're all confident for. And there's increasing some words. There's some interesting but significant persons in postgraduate training in the United States a year ago. They said in a
conference, I think, really. It's rather a peculiar feeling to have the disembodied voice of my ex-boss here, somewhat discomforting and spooky, I would say, really. And it's interesting that I come at this issue of students as partners from an active educationalist, that is someone who's already looking at our new curriculum and actually how students should be engaged. And I think student engagement is a very trendy word, which encompasses a huge amount. And students being involved in their own education, we all feel that's a good thing. Actually, I've just been involved in a 2-day review of students as partners in Malaysia. And what you find out is when you actually talk to students is not all of them want to be involved as partners. Actually, when people are 18 and growing up and leaving home and learning something new, they've got a lot on their hands. Do they actually all want to be part of being a partner in their own education? And so I think we should dispel that myth. Some clearly do and want to, but not everyone wants to. The other thing I would challenge is, so surely it would be better asking new graduates rather than our students how they felt that. Now we can ask students how they felt about the delivery. Was the delivery of
always supported and promoted ICME at the World Forum. Ever since we launched the conference website, I have been closely monitoring the hits. There were on average 30 new hits every day from almost all the countries of the world. The response conference workshops. Most encouraging is the fact that there were 48 abstracts were received from more than 12 countries other than Pakistan. Similarly, the submission for pre-conference workshops were also more than expected. We received about 36 proposals, of which 32 were accommodated in 2 pre-conference days. The scientific committee, under the leadership of Professor Rehan Ahmed Khan,
by Rafa International University in 2009 to provide a credible platform for interaction of world-renowned experts in health professions education and those from developing countries aspiring to reform health profession education in their countries to bring them at par with international standards within their local context. The first ICME was held in Pakistan in 2009, which resulted in recognition of health professions education as a specialty in medical sciences and the compulsory establishment of Department of Medical Education in all medical colleges. Encouraged by the response, ICME was then organized in other countries undergoing or planning for reforms and in health professions education. I would also like to share with the eminent participants here is that as a result, and I believe as a direct result of 2009 ICME, the then Pakistan Medical and Dental Council selected a cohort of 5 universities, which they allowed, which included Rafa, Khan, Dow, and there were 2 other medical schools, to develop a curriculum which is based on a modular format, which was embedded with problem-based learning principles, and which was substantively vertically and horizontally integrated. And that happened first time in the Pakistan. And after almost 5 years of that pilot, PMDC finally gave the choice to the medical colleges in Pakistan to continue with their conventional curriculum or undertake experimentation and innovation as we've done at Rafa. So I think it was possible because of everyone who's here and all the experts that got together. I'm very happy to see Dr. Brownie, who was also at that, she's a pioneering keynote for us. And so that humble journey which started, I see Professor Umar Ali of Education. And sir, we hope that all these experts are there for the government to make use of. And we would like to professionally contribute to development of this profession in Pakistan. Ladies and gentlemen, over the years, the paradigm of medical education has shifted from teacher-directed to learner-directed. But when you consider that even in advanced healthcare systems of United States, human errors, and I mean preventable human errors, miss 70 years, and it's time that we are bold like our health advisor, special assistant to health, and think about our curriculum accordingly as well. Maybe we need to take those huge documents and put them aside and start to think about medical education, healthcare professional education from scratch. Scary it always is. I also take this opportunity to welcome you to the city of Islamabad. I hope that you're able to take some time out during the conference to see and explore our very vibrant city. Although the program that has been put there by General Masood, so he's all work, no play, and he expects the world to go by his philosophy. 8 to 5, General Sahib, a very tough program, but I hope our delegates would come and enjoy the city. Thank you very much.
Educational, cultural needs of a student and develop our curricula based on that. Rafa has developed a model-based system where we expose our students to problem-based learning, and I'm proud to say that among those problems we have also included social, religious, ethical issues. So our graduates, inshallah, will be able to serve better society and community. I welcome all overseas resource persons, and I hope these few days will not only enhance knowledge, but give us confidence in improving mental health, spiritual health, social health of people. Thank you very much.
First of all, truly it's a privilege to be here this morning in this ICME conference, and I really appreciate Rifa University for taking up this very important and ignored area of medical education and taking it to a level where you are being invited by other countries to organize collaborative conferences. So I must congratulate you, and I appreciate that very much. It was said that for reforming Pakistan and towards Naya Pakistan, some radical and drastic measures needs to be taken. So let me give you a broad angle view about the government's vision of healthcare in Pakistan very briefly, and then come to the drastic measures which were referred to, because I am sure all of you are interested to know that how the future of medical professionals, medical practice and medical education looks like in this country. So as far as the vision of the government and the Prime Minister Imran Khan is concerned about the healthcare in Pakistan is very straightforward. He wants to create a welfare state in Pakistan, and one component of that welfare state is universal health coverage for all Pakistanis. And universal health coverage is understood, however, by different people in different ways. And I think what is very important is that all of us to be on the same page, that when we as government talks about universal health coverage, what do we really mean by it? So basically, universal health coverage has three components to it. First and foremost is that according to the needs of the people, regardless of their status in society, their gender and their geographical location and their belief system and all what discriminate among people, according to the needs of everybody, as the right of the people, the healthcare needs are met for all Pakistanis, whoever they are. So that's the first component. The second component is that among us, those who do not have ability to pay should not be denied a same level of health care, which is their right, just because they don't have money in their pockets. And that's where the notion of social health insurance comes. And it begins by covering those who cannot pay. Healthcare cannot be and should not be denied to people just because they cannot pay. And that's where social health insurance in the form of Sehat Insaf Card, the scheme that this government has perpetuated to a level that by next year, by the end next year, all poor families, as they have been identified by a national survey, as it is recognized by NADRA database, will be provided a Sehat Insaf Card so that a family member in a poor family, when falls sick to a level that he or she needs a hospital admission, they don't have to care that they have to sell their belongings, or they have to go for debt, or they have to plead the local political leaders for recommending them to the hospitals. They will be admitted in the hospitals, predominantly in the private sector hospitals, and government will be taking the responsibility for paying their premiums through state life to these hospitals, and hospitals will be obliged to provide them a same level of health care as they will be provided to their rich customers. So that's the idea of Sehat Sahulat or Sehat Insaf Card, which is a kind of health insurance for those who cannot pay, and which is a second component of universal health coverage that the government is perpetuating in the country. This is radical. You can clap more loudly, because this is because the clapping was very meek. But this is radical. Nobody could have thought about it, that in Pakistan a day will come that a poor family will not have to worry about their health care just because they cannot pay for it. It is drastic. Alhamdulillah that we are able to do this. And the third very important component is the quality of care. Providing health care to people who cannot pay does not mean that we also downgrade the quality of care. And quality of care is an integral component of universal health coverage. So if this is the vision, obviously we have to reset our healthcare system, the way it is organized, the way it is managed, the way it is financed, and all components which feeds into creating and establishing a modern healthcare system needs to be in place and must be in sync with each other. What are those? Health governance, health financing, health workforce, health information, health services. All these needs to come together. And then, of course, last but not the least, private health sector. In Pakistan, government is not being able to provide health care to more than 30% of its populace. Traditionally, we have been low spenders in health and education. It is going to be changed, but it will take time. As Pakistan's economy would stabilize, that is the first priority of the Prime Minister. But nevertheless, the fact remains that 60 to 70% of people go to private sector. So how the vision of universal health coverage can be realized if such large number of people are going to the private sector? There is a way to go about it. And that way is that government, as it will increase incrementally its healthcare financing, the government will start purchasing services from the private sector for the benefit of the people. And as I just gave you an example, Sehat Insaf Card, actually we have empaneled around about 300 private sector hospitals, and government is purchasing services for them, for the people. That's what the form public-private partnership will take in the context of universal health coverage. Now, in this context, among all the components of the healthcare system that I just mentioned to you, I mentioned health workforce. And health workforce is so basic and so fundamental without which no healthcare system can function. The numbers of the healthcare professionals to run the healthcare system, their quality, and their mix. And by mix I mean how many doctors you need, how many nurses you need, how many pharmacists you need, how many physiotherapists you need, and what balance between the health workforce you require to move reasonably towards realizing the vision of universal health coverage is fundamental. So in Pakistan, we have challenges on all these accounts. The numbers are not good enough. The quality, the education and training, which I will focus in a minute, is not good enough. And we are imbalanced in our health workforce. Just to give you one example. All over the world, and World Health Organization recommends that there must be 3 to 4 nurses for 1 doctor. In Pakistan, we have 3 to 4 doctors for 1 nurse. So that's the kind of mix that I'm talking about. It's an imbalance. We have to correct these imbalances in our health workforce production and in our health workforce training. Now, obviously, especially those of you who follow very closely the regulatory dimension of health workforce in Pakistan are keen to know that what has happened over the last 36 hours in Pakistan when the President of Pakistan on the evening of Saturday signed a law and gave life to it by making it an ordinance, which we are calling Pakistan Medical Commission Ordinance 2019. It is fundamentally one of those efforts by the government to correct those wrongs and to update our institutions and our systems who can become more fit to the purpose and who can become more efficient and deliver those results which we all want to see them delivering in order to feed into that vision that I talked about. Pakistan Medical and Dental Council was born in 1962, and that was the year when I was also born. So it's about 56 years old. It has served its purpose. Things have changed. It needed to be upgraded. It needed to be updated. Attempts were made incrementally over the years to improve it and make it fit for the purpose, whereas the medical education and medical profession had really advanced. Super subspecialties have been created. In the meanwhile, in 1962, when PMDC was created, there were a handful of medical institutions in Pakistan. Today, we have 168. Majority of them are private sector hospitals, medical colleges and universities. And majority of them have come into being in last 15 to 20 years. Without going into the details, why it happened, who did it, and what were the intentions, and who benefited from them, the result is that today, as I stand here, I cannot confidently say that the quality of doctors and dentists which will be produced and which are being produced, if corrective actions are not taken, that whether I would be able to send my grandson or granddaughter to a doctor with this confidence in future, that that doctor or a dentist have been treated according to the optimal standards, minimal optimal international standards of medical education and training. That's the concern that we have. And that is the moving force behind these drastic and radical measures which were referred to, through which we are trying to improve our institutions, our legal frameworks, and their functioning. So, we have introduced Pakistan Medical Commission, which is actually rebooting, if you like, rebooting PMDC to a next level. A new body corporate has been created, which consists of 3 components, one of which is actually Pakistan and Medical Dental Council. Second, National Medical and Dental Academic Board, in order to make a clear distinction between the regulatory function, licensing, etc., from setting the medical curriculum and the standards of medical education in Pakistan. And these functions need to be distinguished. A confusion had been created at institutional level where those who needed to be regulated were being regulated by those who also had vested interests in the same system. And the third leg of this new body corporate is National Medical Authority. And the National Medical Authority is, in simple words, the secretariat of the commission. The Pakistan Medical Dental Council will be consisting of 9 eminent, very well selected and appointed members by the Prime Minister. The National Medical and Dental Academic Board would have 19 members of absolute credibility and eminence on clinical side, on basic sciences side, dental, etc., etc. And National Medical Authority will be consisting of 7 highly qualified members which are required and which will lead their respective departments in this secretariat of the Pakistan Medical Commission. What changes? First of all, this distinction that I talked about, and very important difference that the new system would have, apart from having good governance, transparent way of working, efficient way of working, people will not have to wait for months and months for recognition of their degrees when they come from abroad. People will not have to wait for their licenses or registrations to be issued for years and years. It will be a time-bound system which will be working in an automated way. But one major difference that we are bringing in is that through this Pakistan Medical Commission, we are introducing National Licensing Examination. National Licensing Examination will be an examination which every graduate, medical and dental graduate, will have to clear before they are issued a permanent license. This is our way of putting a very strong filter at a point when doctors or dentists have graduated from their institutions, whichever institutions they have graduated from, a legitimate institution, however, which itself is licensed, but perhaps some of them are still falling short of those minimum standards of medical education that I talked about earlier. So all of them will have to go through an examination to acquire their license, and this examination will be happening one day, twice a year, and every graduate will have to pass that examination to acquire that license in order to be able to practice in Pakistan. This, ladies and gentlemen, is an indirect way of ensuring that that we have created over the last 15 to 20 years by way of liberalizing quite tremendously medical education and training in Pakistan through private sector, no harm in it, but they have to live up to certain standards. I should be feeling confident to send my grandson to a doctor with this confidence that this doctor or lady doctor or a dentist has been trained rigorously in a system which meets certain standards of medical education and training. And this, we feel as government, that if we don't do this, we will not be performing our duty. We will not be serving the public interest enough, and we will be negligent in our responsibility and duty to safeguard the public interest. A lot can be said about this new ordinance, and as the ordinance will become available, as it will be notified today or tomorrow, people will put it under microscopes and they will try to understand it. But this is the gist of it, and this is the rationale for it. And I think this is most important to be understood, that why we are doing it, then what we are doing it. Last but not the least, since many experts of medical education are sitting here, let me also make a provoking statement for your reflection and deliberations in this conference. When I was trained as a medical graduate and when I passed out, if somebody would have asked me that, do you understand the healthcare system in Pakistan? Do you understand what primary healthcare is? Do you understand that what universal health coverage means? Do you understand the notion of vulnerability in healthcare? Believe you me, ladies and gentlemen, I would have not been able to answer that. Because my curriculum, my training, my teachers, my worthy teachers, who themselves were part of that system, were not trained themselves to train me. If you ask today also our average graduate of medical college or a dentistry college, that what is the infant mortality rate in Pakistan and what government should be doing and what as a fresh graduate, how you will be contributing to it, you will get silence. Why there is so much stunting in Pakistan and how we are training our fresh graduates to deal with it. We should ask ourselves that is there a disconnect between our medical education and training and the problems that this country is facing. I thank you very much for your attention.
Congratulating Zafar University on this wonderful conference and inviting so many people from all over the world to participate in it. These kinds of conferences go a long way in improving the standards that we've been talking about. I'm also very grateful to Zafar University for inviting me, although I'm not a doctor and I don't know much about medical education, but I have learned a lot just by being here today, and I'm sure many other people like me would have benefited greatly from this conference. Dr. Zafar Mirza spoke about reform, and this is what the people of Pakistan elected us to do, to carry out reforms in many fields, and including health. The difficulty is that unworkable systems create its own, shall we say, camp followers, its own vested interests. So whenever you try to make an unworkable system workable, there is a reaction. Those whose interests are aligned with that deficient system
start to raise their voice. And so one of the challenges of reform in any part of the world, and one of the challenges of reform that we are facing here today, is the reaction that we see in different fields. I'm not talking just of health. Reactions that you see when you try to carry out fundamental reform. In the field of health, there are one or two things which are very obvious. Some of it may be a little controversial for me to comment on, but take, for example, this whole idea of involving the people in the management of hospitals. What we are trying to do is only have eminent citizens of that area involved in ensuring that the quality of healthcare being provided by the hospitals is of a certain standard. And that can only happen because if there are people who represent the beneficiaries of that health facility. So we have decided that there should be board of governors for various hospitals, and these board of governors comprise of eminent people, and these eminent people belong to the community, and the community through them takes control of the kind of healthcare that is being provided to them. And you start hearing all kinds of things. Government is privatizing health systems. Government is not privatizing health systems. All that the government is trying to do is involve the people in and involve the community in the management of healthcare. But you hear all kinds of constructions being put on it. This is particularly also true of many other things. And what Dr. Mirza, who's doing a tremendous job as our health minister, what he spoke about just now, and that is something that concerns me very much. It's of great, and we've been spending a lot of time thinking about this thing. Because education must have two things. Education must have quality, and education must be relevant. We have a situation, for example, of lack of relevance where people who have done PhDs are unable to find a job. And one of the pressures that I face on a daily basis is from people who have PhDs, and they are saying, give us jobs. So there is obviously some kind of disconnect between the kind of education that they are receiving and whatever the job market demands. But quality is exceedingly important. And that has been something that has been engaging my mind and the mind of the Education Ministry, that how do you raise quality standards? So many things are being attempted. There is faculty development is happening, other things are happening. But I think one of the outcomes of what Dr. Mirza and his team are trying to do is to raise these quality standards of every medical institution in the country. Because what will happen when once you have this equivalence exam, before even I knew about the details of this system, I just asked Dr. Mirza that with so many medical institutions, we need to have some kind of equivalence. And now, I'm a lay person, and the first thing that occurred to me was that we have 168 educational institutions, and how do we ensure that each one of them is providing the right kind of quality? And therefore, if you are going to have a countrywide examination in which every graduate of a particular college is required to take up that exam, what will happen over a period of time is that the quality standards of every teaching institution will start to go up. Because if the quality standard is not there, people would stop going there. And if people stop going there, the colleges would fail, many in the private sector. So therefore, I commend you on this step, and I think that this is long overdue. In fact, similar steps need to be taken in other professions also. We need to make sure that engineers, social scientists, whatever. I'm told that in the United States you have something similar. Now, why was it done? I know that for example, lawyers have to take state examinations before they can practice law. Even a Harvard graduate would have to go and take the state examination. Why? Because there are so many law schools that you need to have a certain equivalence. And those exams, I'm told, are very, very difficult, in some ways more difficult than the university exams. So I think one of the challenges, Dr. Mirza, that you would have in this is to devise an examination system in the medical profession which judges all the different aspects. I don't know how you create equivalence among surgeons. Will there be practicals? I don't know. You are the best judge. But I'm sure that will be done with great care and would cater to all the requirements of quality and standards. So I really don't have much more to say on this particular subject, but I wish this conference all the best, and I hope that out of this conference will emerge many very good suggestions, very good, and maybe suggest a way forward in education, medical education, and trying to take care of some of the problems that we have in the healthcare. Lastly, let me say one more thing. The health card. This is truly a revolutionary step. That, I come from a village in Pakistan, and when we were growing up, we were told that there are two things which can destroy a family in the rural areas. One is if you get involved in a court case, because court cases are lengthy and take away, people have to sell all their property just to go through the court process. And second was if you have a sickness which requires hospitalization and long-term medical care, that destroys a family. So the fact that the health card is going to provide relief to poor people and give them high standard medical care is a huge thing. I was once told, and I think that is a very important aspect of this, that every maternity situation in the rural areas wipes out the family if the mother has to be admitted in the hospital and to take care of the entire process. So this, I'm sure, will also help in that sense. So thank you again, and to our foreign guests, it's a lovely day today, beautiful sunshine, nice weather. So I hope you get an opportunity to see this wonderful city of Islamabad also. Thank you very much.
Now I request Chief Guest, Mr. Shafqat Mehmood, to offer souvenir to respected guest of honor, Dr. Zafar Mirza. Zafar Mirza, please come on the stage. Humbly request Mr. Shafqat Mehmood to present souvenir to Chancellor Refined National University, Mr. Hassan Muhammad Khan. Now Vice Chancellor Refined National University, Professor Anis Guest.